All right. Everybody ready? Okay, so what we'll do is next time, we'll get those multiple answer questions that I think is better. But otherwise, we'll go through the question answers here. And let's start. Just to say, look at that. When I took the exam in 2001, 2000 and 2001, passing rate of cardiology board was only 70%. Lowest of all the subspecialties. Now we got better. It's now 88%, just like others. So that's good. Okay, so question is, you need to remember these updated now the guidelines in terms of class 1, class 2, what strength and what level of evidence. So they have made little changes than classical or class 1, 2A, 2B, and 3 all have changed a little bit. So make sure you understand basically that they'll give you the scenario and ask where this will fit in. More important is in the class 3. Class 3 has two types now. Could be harm or the no benefit. So could be any, like NSL cysteine we talked about. No harm. But doing a PCI in occluded vessel, asymptomatic, is harmful. So therefore you have to remember that could be harmful or no benefit. Then in the level of evidence, they want to be a little more detailed for us to understand that it is A, B, R, it means evidence is one trial versus moderate evidence with the meta-analysis and the non-randomized data and EO. So all these things you need to remember. They will give the scenario, ask you which type of evidence it is. And most important is the last 1 year or so, 1, 2 years, because guidelines keep changing. Definitely nothing for last, I would say, probably last 1 year. It's anything before but first quarter, like let's say ACC of 2023. Before that, or maybe even not 23, so 22 and earlier. Those will be the questions. So anything after that is not counted. They will not put those questions because questions have been set last year. So last year they were set by the questions before. And they do, there are a lot of set of people who give the exam. And I did my first ones, of course, 2000 was the first interventional cardiology board, all full, they call it a not 9, 10, 10, 10. If you do, only thing I missed 6 questions of the imaging. And since then, all time has been 10, 10. So only problem will be that I'm in the second round of being the board exam setter for the ABIM. If I get it, which we'll know in September, then I cannot give the board review. So next year, my other associate can give it, but at least still enjoy. So they make it that once you are examiner, you cannot give the board review because you have a tendency, you are going to tell people what you are writing. So anyway, with that note, let's start. As we talked about the ABIM website, the question is textbook and practice guideline published in last 6 to 12 months before the examination is the one they are expecting you to. Okay, quick. What is the abnormal finding on this IVUS imaging? What do you see? Okay. So clearly this patient has dissection, right? Very significant dissection. And these are the IVUS images of the dissection on the left, malposition. You see that? Then thrombosis, clear-cut large thrombus right there. And you have the neointimal hyperplasia, ISR. So they'll show you those pictures. So where this patient fits in. Okay, imaging. Both OCT, IVUS will be at least 10, 12 questions. There will be 5, 6 questions on the radio. Make sure those hand out, read them, because nobody teaches them. So you need to remember, they'll ask exactly the same question. What is the minimum RAD, this annual allowance rate, and so. One simple, they show a patient is that one picture, and then the second one, the camera has gone up. Remember, then picture become big. So basically, is that your eye tube has moved up. So simple things. Okay, on OCT, what is the finding? Marana showed it. Calcific lesion, absolutely. So this is the calcium, which is and these are the findings, fatty lipid plaque. What is a lipid plaque? It's not a well demarcated like we saw in the calcium. So it is basically confluent. You see that lipid plaque? It is just basically that there is additional, sorry, there is no pointers here. But anyway, the key is that the plaque basically at your lumen and no confluence, no clear cut like calcium. There is a there and here on the top at 11-12 o'clock, sorry, 11-12. See that? That's the plaque. But that's a fatty plaque. Then you see the dissection, then you see the thrombus. Remember those. And again, as I said, these all will be for you. So more pictures we are trying to show on the IVUS and the OCT, that how the fibrous plaque will look in both, how the lipid plaque will look in both, and the key is there the thin cap fibroatheroma, and the number is 65 micron. So if it is less than 65, although they will write the number, you can't measure there, but 65 micron is for the thin cap FCT. And then the calcific plaque, we already said, IVUS, there is no shadow behind. So as question was that IVUS is also good for calcium detection. But what difference between IVUS and OCT in terms of calcium? Depth, particularly the depth. Otherwise, you can see the arc in both. You can see the density, but you cannot see the depth, thickness. And thickness is the important point, which comes back to, we'll show you some calcific, those OCT scores. Okay. Now, based on the definition 2 criteria, following lesion scenario is appropriate for single stent strategy versus 2 stent strategy, except main vessel 3 mm, side branch stenosis 70%, main vessel 3 mm, side branch is lesion length less than 5, main vessel 2.5, side branch is length is 12 mm, side branch mildly calcified, bifurcation angle 55. So question they are saying is, all are good for 2 stent. Where you think you will be successful with the 1 stent strategy? That basically the question is here. Which group, which you think will be the single stent will be good? B, because the length. See, so these are the criteria. The major and minor criteria basically, you will be able to see it later. But 10 millimeter length, 70% diameter stenosis. In the left main, that's a 50%. And the other question is, if you are able to protect the side branch, in the angulated side branch will be also that you put a 2 stents. So you will not be able to wire. So those cases also you put 2 stents. So basically these are the definition 2 criteria. So anything less than 10 millimeter, vessel size more than 2.5 or 3 is the one good. You can come out with a single stent. Your 2 stent is required in everybody else. Okay. Following randomized trial of bifurcation lesion PCI have shown 2 stent strategy superior to provisional 1 stent strategy, except DK crush 3, DK crush 2, Nordic bifurcation 4, or EBC 1. The 2 stent strategy superior to provisional stent 1 stent strategy. So which one is wrong, right? They're saying that all are there except one of them is not comparing the 2 stent versus the provisional stent. Which one is that? Okay, EBC 1, okay? The EBC main trial. What was the EBC main trial? Basically was stepwise. Remember the EBC main trial was systemic, dual versus stepwise provisional. And in this one, 2 stent strategy was not superior. Now at the 5-year data, 3-year. Now they have the 3-year data of the EBC main. There is a lower TLR in the provisional group. But that's 3-year. But that's only came out this year, so won't be counted. But basically, there's no difference in the 2 stent approach in EBC 1 because DK crush was better, 2, 3, and Nordic bifurcation. And here are the individual. DK crush 2 trial and was the trial of double kissing versus provisional stenting in the coronary bifurcation, coronary non-left main. Again, DK crush was superior. Then the DK crush 3 trial was in the left main. And what they compare there was the DK crush against culotte. And basically DK crush was superior. And then the Nordic bifurcation 4 was the trial of provisional side branch stenting versus 2 stent in the large vessels at 2-year follow-up. And it clearly showing the 2 stent technique is better than the single stent. EBC main, we talked about the data and so. Okay, following are the appropriate suggested technique of rotablation procedure except packing motion, ablation of 180,000, continuous forward motion of the burr, ablation time of 15 to 20 seconds, which is wrong. C, continuous forward motion. Where do we use the continuous forward motion? In orbital atherectomy. There you go continuous. Here is the packing, back and forth. Okay. These are comes out from our paper in circulation. Okay. After the main vessel stenting of the side branch was needed to have optimal angiographic result because you didn't have good results of the side branch. In this scenario, which of the following technique is not recommended? You put see the question, stent of the side, main vessel stent, side branch, good results, provisional stenting. Now you have to put a stent. So which one is not recommended? DK crush, reverse crush, tap technique or coulot? There is no DK crush now. Right? It could be reverse crush, tap, because DK crush was strategy of 2 versus provisional. You already failed there. So this will be now not a DK crush. So what you do is a coulot, T-stenting or mini crush. These are the ones basically we know how they are. More important for the bailout are the tap, reverse crush and coulot. There are plus and minuses of both, but most of them, they want you to kind of either do a coulot or tap once your side branch issue, because you need to cover the ostium. And therefore, this is the DK crush is out of the question because that's already failed this case. Okay. Always there will be 1 or 2 questions on this. Proximal LED, DES had a 9-month follow-up angiography following are the QCA parameter. Pre-MLD 0.8, MSA post 2.5, MSA at 9 months is 2.3. So what is the acute gain for the LED lesion? You have to calculate in your mind. What is acute gain? And what is acute gain is your MLD pre to MLD post. And then what is the late loss? MLD post minus MLD follow-up. Okay. So therefore, in this clear-cut case is a 1.7, and this is where acute gain, net late loss, net gain, and loss index written there clear-cut what it is: late loss, net gain, and acute gain. Okay. Then syntax 2 score, in addition to the syntax score, incorporates the following characteristics except female gender, CVA, COPD, and LVEF. Remember, syntax 1 are all anatomic. Syntax 2 incorporate many other factors. So basically, it incorporate your female gender, COPD, LV, creatinine, and peripheral arterial disease, and so. But CVA is not the part of the syntax 2 trial. Okay. And these are and then what they do is based on the syntax. This is also available from the website. It gives you the chances of that. What are the chances of event mortality of at 4 years, 3 to 4 years in the patient going for PCI versus cabbage. Okay. SVG intervention following have been suggested as a useful adjunct, except 2B3A, distal protection, both DS and BMS, vasodilator infusion. What is wrong? Except means always think, if they're saying except means that's wrong. Otherwise you'll be, sometimes you know the answer, but you'll answer wrong. Except means that what is wrong? 2B3A. 2B3A is not good. There are data clearly that these are the guidelines, remain same in the latest guidelines also of 2015. They didn't make much changes. That end the SVG PCI distal protection device, embolic protection device was class 1. Only thing changed is now it has become 2A. No longer class 1. So distal protection, every case is not needed. It's become 2A. And of course, play 2B3A are not beneficial. As you see, this will be 3 of no harm. Harm is different, and the PCI is not recommended for chronic SVG. This will be harm. If they show you that case or so that patient with a thrombotic vein graft, chronic SVG occlusion, so that case is thrombotic occlusions and so of the vein graft is harmful. So you embolize distally, you go to native vessel. And they also have, these are our rest of the guidelines. Patient previous bypass, patient of use of an embolic protection device, I told you, became 2A. These are the latest guidelines. Patient previous CABG, PCI of a diseased native coronary artery is feasible, then it is reasonable to choose PCI of the native coronary artery or PCI of the severely diseased. And no benefit, we talked about chronic occlusive SVD. So instead of harm, now they go to the no benefit there. So key is they give you a scenario, very thrombotic graph, and the native vessel, or even a thrombotic, but it's a focal lesion, and they show you the native vessel. So if native vessel is easier to approach, it's not a bad CTO calcific, answer there is go to the native vessel. Vein graft PCI is a trouble, and don't do that. Okay. Following are the trials of PCI using atherectomy devices except Rotexus, Prepare Calcium, Eclipse, and FAME3. FAME3, right? That was a trial of the FFR guided PCI versus CABG patient with multivessel disease. The Rotexus trial, what did the Rotexus trial basically show? That there was, although strategy was better of the rotablation, basically was rota versus standard therapy followed by tax assistant, but there was no difference in restenosis. Strategy, better success, less bailout, about 16% bailout happened in the standard therapy group, but overall outcome was not different. Then same guys did a prepare calcium. This time instead of a standard balloon, high pressure, they use a scoring balloon or cutting balloon. The message was about the same. An Eclipse trial is a trial of orbital atherectomy, first of the trial. If question about the orbital, has there been a randomized trial of orbital atherectomy to date? Answer is no. This is the first trial likely to be presented in TCT this year. It's the OA versus non-conventional strategy. Rotablation was not allowed to use in the standard group arm in this case. FAME3 trial, which is a clear cut, right? And also the important endpoints. You have to remember that what was better for CABG, death, MI, and stroke, all the primary endpoints. There was no difference in death alone. There was lower myocardial infarction and lower revascularization. So that is the key. Stroke rate was not different. The lower MI, lower revascularization, and lower MI, the lower MI and lower revascularization, no difference in death, as well as primary endpoints were in favor of CABG versus PCI. In the low risk group, the low syntax group, PCI did better compared to CABG in these patients. Okay. All right, those who are involved in the intervention should know this. Which of the following guide wire sizes and the guide wire used? Sizes with the guide wires used. 009 guide wire body, 009 guide wire tip, 0.012 guide wire tip, 0.012 guide wire body, and 0.014 guide wire tip. So these are the various ones. So we know that the tip of the rota wire is still 0.014, but it's the body which is 0.009, right? The viper wire is 0.012. Clear? So confianza, it is 0.009 tip. The miracle bro is your 0.00 guide wire tip. And then Gaia next is, and rota wire, sorry. Rota wire will be 0.04 guide wire tip. So basically, A, rota wire, D is the viper wire, which is 0.0 guide wire body, B, confianza, it's 0.09 guide wire tip. Miracle bro is E. Tip is 0.014. Body is also 0.014. And Gaia is C, is 0.012. Gaia next. Okay. Now these are the individual which we have from the guide wire app. From Kini, we have given all the features in there. Okay. Following statement is false regarding PCI via radial approach versus femoral. I know we talked about it. So this is actually goes back now, the latest guideline. I know Barman presented, but he didn't present this. This is very important, and you need to know the answer. Radial over femoral approach is class 1 in patients with ACS to reduce death, vascular complication of bleeding. Benefit of radial over femoral approach PCI is more at high radial centers and operators. Radial versus femoral approach is class 1 in stable ischemic heart disease patient to reduce vascular complication of bleeding. And then radial versus femoral approach is class 1 in stable disease patient to reduce death. So question is, following statement is false. Which is wrong? D. Clearly, so this is basically the guidelines are, the latest guideline of 2021 is only bleeding and vascular complication is stable disease, but all three, including death in patients with acute coronary syndrome. Okay. Meta-analysis of DS versus CABG in left main CAD has shown the following, except similar 5-year and 10-year mortality, higher MI in PCI versus CABG group, higher revascularization PCI versus CABG group, significantly higher CV in the CABG versus PCI group. CVA. So CVA basically not higher, not significantly higher. This was the, remember, meta-analysis of the 5 randomized left main trial CABG versus PCI. So every year, 0.2% higher mortality with PCI versus CABG. So it was 1% versus 2% at 5 and 10 years, not statistically significant. But higher myocardial infarction, higher revascularization, stroke rate, numerically slightly different, but not significant. Clear? Which trial of interventional trial of the left main where it was shown higher CV rate with the PCI versus CABG, higher with the C, only one trial, Noble. Noble trial showed higher CV rate compared to CABG, in the PCI compared to CABG. Okay. All the steps to advance rota to distal RCA with severe calcification and eccentric tortuosity have failed. So rota you cannot get. So now what is the next step? Use 7 French guideliner distally and then rota bar. So use 7 French guideliner distally and IVL catheter. Use a body wire technique and high pressure balloon dilatation with or without guideliner. Then use your excimer laser with guideliner and all of the above. What we do in real life, all of the above. Right? Everything you will be able to do because 6 French guideliner will not take the rota. You need a 7 French guideliner. Okay. Now, which of the stent is stud thickness with a corresponding stent type? 60 micron, 74, 81, 89, and 79. Lowest is 60 micron. Which is a 60 micron? Or 0. Very, very good. Okay. Then the second one is 74 micron. So you remember the synergy of various sizes have a different there. So synergy 74 micron is B or 0 we already said. Science is C 81 micron. Synergy Megatron is 89 micron and Synergy 3.5 is 79 micron. And I have the sizes which is putting here. Okay. As per ACCHA revascular guideline of 2022, following lesion scenario is no longer the class 1 indication for CABG. And these are the guidelines. So 2 years ago, they will be in the questions. Multivessel disease with EF less than 35, multivessel CAD with EF more than 50, left main CAD with high complexity, left main CAD with high complexity and suitable for CABG, which is no longer the class 1 indication for CABG. B, right? So, and that basically is that on the right side, the once your ejection fraction is more than 50%, multivessel CAD became class 2A. No longer class 1, so both 2A for PCI and CABG. And this is more detail of the same. On the right side, more than 50%, as you can see there, CABG and PCI both are 2B indication. And no longer class 1. Otherwise, low ejection fraction, left main complexity, those remain class 1. And as you can see, the PCI, of course, in selected cases, after heart team discussion, they allow it, that can be done. Okay, then we talk about, so then this is also may come in some type of a question format that patient with previous CABG with a patent lima to LAD who need repeat revascularization, PCI is feasible, it is reasonable to choose PCI over CABG. Patient with previous CABG and refractory angina on medical therapy attributed to LAD disease, it is reasonable to choose CABG or PCI when IMA can be used as a conduit to LAD. So they'll show you the complex LAD disease with a moderately high syntax score, and basically is that this case can go for re-CABG. Lastly, in patient with previous CABG and complex CAD, it may be reasonable to choose CABG or PCI when an IMA can be used and conduit to LAD. Basically, they're saying that anytime you have a complex CAD and lima is available, that is your choice. That basically the question is. Because most of the benefit of the CABG is only with the lima. Okay. Percent of cases was device failure in the non-rota group in the calcific lesion of the Rotaxis trial, which I just said. Rotaxis prepare, which was 16% in both the trials. You see that both of them 16% failure rate. Crossover because of could not cross, or the device embolization. So 16%. Okay. OCT-derived calcium scoring system include the following except calcific angle more than 180, thickness more than 0.5, calcium length more than 5, calcium nodule more than 1 millimeter. Nodule is nothing to do with it. Absolutely. So all criteria shown there, nodule is not there. Okay. Following are the OCT-derived features of vulnerable plaque, except fibrous cap thickness of less than 65, large lipid pool, activated microfluid pool near fibrous cap thickness of more than 85. 85. Very good. We talked about it. Good. Thin cap fibroid thromboma, other features I have added on, which you need to read. Okay. Now, which match the following trials: FFR versus IFR trial, PCI OMT versus ischemic cardiomyopathy, FFR guided versus IVUS guided PCI, bivalent versus heparin during PCI, FFR guided versus angio guided. Okay, FFR versus IFR trial. Very good. PCI versus optimal medical therapy in ischemic cardiomyopathy, revived BCS2, FFR guided versus IVUS guided PCI. Good. Bivalent versus heparin during PCI. Bright 4, FFR guided versus angio guided PCI, your floor MI. Okay. So revived BCS, no difference, even no change in ejection fraction. Very important. We thought that maybe in ischemic cardiomyopathy by PCI, EF will go up. No difference, and everything was, except unplanned revascularization was lower in the PCI group compared to medical therapy, which I expect. You leave all the lesions there, they require intervention, but nothing else there. Then flavor, IVUS was FFR guided, no difference. Then lastly, Bright 4, bivalent with a 4-hour infusion, not bolus only. Bolus plus 4-hour infusion was superior to heparin alone, and defined flare, we talked about it, IFR versus FFR, basically no difference at 1 year. Okay. Flower MI, which basically was the trial of FFR guided PCI versus angio guided complete revascularization, and showed that angio guided PCI, actually FFR guided PCI has little higher trouble, but not better. Some points were actually negative. So it was not a superior trial, but no difference. But many of them repeat revascularization, MI, they were a little higher into the FFR group because you left those lesions alone. And you can see here, any hospitalization cardiology, higher in the FFR group versus angio group, significantly higher. So key is, there is a trial which we have, post-MI, FFR guided strategy was inferior to the angiographic guided PCI, and that is the flower MI trial. Okay, coronary angiography performed in 48-year-old woman after abnormal stress test, multivessel disease. Which of the following is not an important factor in selecting PCI versus CABG? Diabetes, syntax score, target vessel revascularization, or age of the patient? Age, right? Age of the patient. It does not matter. So patient, as long as they're otherwise good, everything else is important. And we know that diabetic patients do better with the CABG versus PCI. And we have the syntax trial with the highest score group patient. Clearly, there is a benefit of mortality. Okay. Which of the, not a finding from long-term follow-up from the syntax trial? So that is, target vessel revascularization continues to worsen in the PCI arm beyond 1 to 2 years. CVA was statistically higher in the CABG patients versus PCI in all syntax group. Cardiac mortality was lower in CABG patients with syntax score of more than 22. And MI is increased in PCI patients with syntax score of 32. So clearly the answer is C. Cardiac mortality was lower in CABG patients? No. In only high risk group, high syntax. So C, revascularization continued to increase at the 5-year follow-up. Then you go to low score, a kind of equal, not much different, including the even CVA slightly higher in the CABG group, but not different. But then you go to intermediate score, still there is no difference in mortality. You can see there, of course, now MI and revascularization is superior. And then lastly, in the high syntax score, there is a lower mortality in the CABG PCI group, CABG group compared to PCI. Only in the high syntax score group, and there everything is high. So CABG, the CVA was not significantly different in the syntax trial. Okay. Coronary angiography in previously healthy 60-year-old woman shows chronic occlusion of the large RCA. With collateral, left coronary tree shows a 60% stenosis of the mid-LAD, which is FFR is more than 0.8. Following is the not an important consideration selecting PCI in this patient. Experience of the operator, persistent symptoms, significant dysfunction of the inferior lateral wall, and large ischemia demonstrable stress testing. You basically see that patient probably infarcted, maybe no ischemia, so nothing to be done. And these are the guidelines. PCI of a CTO in a patient with appropriate clinical indication and suitable anatomy is reasonable when performed by the operator with appropriate expertise. Then updated guideline of 2021 still remains same. 2B, patient suitable anatomy who have refractory angina on medical therapy after treatment of non-CTO lesion, benefit of PCI CTH to improve symptoms is uncertain. That's why they kept it as a 2B, not 2A. Remember that. CTO, they really don't want us to do CTOs, us and you. So it's a very high strict criteria getting 2B because 5 randomized trial, nothing showed any benefit and death and MI, except that there was slightly better, enjoy the quality of life questionnaires and so. Freedom trial compared PCI with CABG in diabetic multivessel disease. Findings from the 5-year include the following: comparable mortality, except means what is wrong. Except means wrong. You should just remember that. Compare mortality in the 2 group, higher MI in PCI, higher repeat reversals in PCI, higher stroke rate in CABG group, higher primary endpoints in MACE in PCI group. What is wrong? A. Really? Higher mortality. Remember, higher mortality in the, clearly, it is 16.3 in the PCI, 10.9 in the CABG group, everything else will use myocardial infarction. And look at the CV stroke, 5.2 in the CABG group, 2.4 in the PCI group, and revascularization was only up to 1 year. They didn't have revascularization after follow-up, only up to 1 year, 12.6 in the PCI, 4.8 in the CABG group. Okay, so therefore, what they have changed the guidelines now is a patient with diabetes and multivessel CAD with involvement of the LAD, very important. They will keep asking with that anytime patient going for surgery, if LAD is not being, lima is not being used, think about that they want you not to do CABG. If they're doing a CABG, they'll keep, putting the word that lima is available or lima need to be done. So key is, what appropriate candidate for CABG with a lima to the LAD is recommended in preference to PCI to reduce mortality and repeat revascularization, which we learned from the Freedom trial. Now, 2A is in patient with diabetes who are multivessel CAD amenable to PCI, an indication for revascularization or poor candidate for surgery. PCI can be useful to reduce long-term ischemic event. So that becomes 2A. So they may give you a case, the patient has a COPD, FEV1 is 500 and syntax score is 35. That case can go for PCI because high risk for CABG. Okay, syntax or the SDS score is high or COPD, that patient has a CVA. Then patient with diabetes who have left main stenosis and lower intermediate complexity CAD and the rest of the coronary artery, PCI may be considered as an alternative to CABG to reduce major adverse cardiac event. So that's a 2B. So basically saying that low complexity, even left main, you can do PCI. Problem is the left main was not evaluated in the Freedom trial, so that was excluded. Okay. Multivessel PCI is planned for a 68-year-old patient woman with diabetes. Renal insufficiency can diffuse the disease vessel. Procedural safety may be enhanced by the following except thienopyridine, statin, N-acetylcysteine, and adjunct treatment with the 2B3 or IV cangrelor. So remember, there's the same thing. N-acetylcysteine, the ACT trial showed no benefit, basically, and so. So therefore, it is now again not useful, not a harmful, but not useful 3A. And then risk. These are the ones which I mentioned. The latest guidelines of to reduce CI and CKD, contrast, administer procedural hydration, volume of contrast, pre-treatment with statin, radial artery if feasible, do not use N-acetylcysteine, do not give prophylactic renal replacement therapy, and delay CABG in patients. So therefore, if a case is done, patient needs CABG. Doesn't go to, unless it's a significant CAD, doesn't go for CABG next day. You wait, basically, at least 3 to 7 days. Remember, the CIN occurs in 72 hours, so you have to delay it there. Okay. The PCI is planned on a 67-year-old man with end-stage renal disease and left main with triple vessel disease. Syntax score is calculated 30. Left ventricular systolic function is markedly depressed. Compared with support using a balloon pump, the use of an impeller device would be associated with lower mortality, lower MI, lower repeat revascularization, high stroke rate, or lower angiographic failure. Which trial they are talking about? Protect 2. Very good. So what is the answer? Lower repeat revascularization. There was no difference in mortality. Basically, as you can see, this was a trial about 450 patients, balloon pump versus Impella, and showed syntax score was quite high, and individual endpoints are right here, that no difference in death, stroke, MI, and only difference was repeat revascularization, because you did more complete revascularization on Impella compared to balloon pump. Now, there's ongoing trial, Protect 4, but they won't ask it because trial is still ongoing. So therefore, now, because there was no clear-cut, and the trial itself failed because of futility, although at 90 days they found little benefit, but because of that, the guidelines are very strict. In a high-risk PCI, not cardiovascular, in high-risk PCI, in selected high-risk patient, elective insertion of appropriate hemodynamic support devices and adjunct to PCI may be reasonable to prevent hemodynamic compromise, but it's a class 2B, not 2A or 1. So we don't have a good randomized or positive randomized trial. 2B. Okay. Every 100 patients treated with primary angioplasty rather than thrombolytic, how many lives you save? Remember, these were the PCI versus thrombolytic therapy trials. 17 randomized trial. Answer is B. 2.1 basically was the difference into those. 6.5 versus 4.4. Now, that's one understood. Now go to the next level. Then they will say what is number needed to treat, save one life. The 21. So basically how you divide? 100 divided by absolute difference in the endpoint. So it's a 2.1. 100 divided by 2.1 will be your 48 to save one life. And also then they call a relative risk reduction. So what is the relative risk reduction is? Absolute difference, which is 2.1, divided by occurrence of non-treatment arm, which is 4.4. So, and then multiply by 100. So relative risk reduction in this patient will be 32%. 2.1 divided by 4.4 multiplied by 100 will be 32%. That is RRR. These are the number you need to remember, because that's the question they will ask you, just like I asked here. Next, a randomized study of 1,000 patients with 13 points. I think you can see it is the same. That one case we are talking about, number needed to treat will be C. Let's go to the next one. 100% this question will come. Patient undergoing PCI and bivalent with creatinine of less than 30. What is the recommendation? Decrease reduced to 0.5, or infusion is reduced to 1. Infusion should be reduced to 0.25, or infusion should remain 1.75 milligram. Reduced to 1 milligram. Okay? So B. And this is actually the guidelines. Basically, package insert also. The standard is 1.75 milligram per. The bolus is 0.75 milligram per kilogram. Infusion is 1.75 milligram per. And then you reduce that infusion to 1 milligram per kilogram. Bolus remains the same. But if you're on dialysis, your infusion is 0.25 milligram per kilogram per hour. Both you need to remember, 1 and 0.25. 0.25 on hemodialysis, or dialysis, and 1 in patient with creatinine clearance of less than 30. Okay. Patient is on aspirin, nitrates, beta blocker, stable angina, hypertension, controlled diabetes with diet alone. Recently, a somewhat more frequent angina. Stress test showed ischemia. Coronary angiography showed 80% LAD, 40% SIRC, 40% RCA. Ejection fraction normal. Which of the following option is correct? Okay. Surgical therapy offers survival advantage over medical therapy. Both PCI and surgery offer a survival advantage over medical therapy. Strict hypertension control is not necessary. According to the Barry and Freedom trial, surgery should be offer a survival advantage over PCI in this patient. None of the above. Little tricky. But if you look into it, your body of the text, you can answer it. What is the answer?
Because he's diabetic.
Diabetic is what? Diet alone only. Let's say even patient is a diabetic on therapy. All in the Freedom and Barry, all were on therapy. Let's say they will write is the patient is diabetic on metformin. Then becomes what answer? Even then. Okay, surgery. Let's go through one by one. Surgery, what this patient has? Single vessel disease. Was single vessel tried in the Freedom trial? No. Which trial evaluated medical therapy, PCI, and cabbage in single and multi-vessel disease, called MASS trial, MASS. That was with the old bare metal stent. then MASH 2 with a drug-eluting stent. And their best outcome was cabbage, second was medical therapy, PCI was on the bottom. Except PCI did better in terms of lower repeat revascularization. So therefore, this patient does not fit into surgical group. Then PCI surgery offers survival advantage? No, not from the freedom, not from the MASH trial. Hypertension control is necessary, very freedom does make it. So none of the above. So this case is none of the above. And this is basically it. All individuals where you have recommend improved survival, which I have put it down with the latest guidelines in these patients, with part of that we have already spoken. Okay, match the following. Again, guaranteed this question will come. Modest decrease in coronary blood flow, decreased myocardial energy metabolism, transient decrease in coronary blood flow followed by normal or high coronary blood flow, then severely decreased coronary blood flow and increasingly decreased MEM lasting minutes to metabolism, and then multiple short attacks of decreased blood flow followed by complete reperfusion. So preconditioning, which one is the preconditioning? Right, the multiple bouts of decreased blood flow, decreased flow, right? Multiple short attacks of decreased flow. So becomes your A. 4, true ischemia is 3, severely decreased blood flow. Stunning is transient decrease, then all of a sudden there is a higher blood flow. And hibernation is 1, modest decrease in blood flow as well as myocardial energy metabolism. Okay. Yeah, this one, you can go through the same question again with the QCA acute gain we showed now. Patient has completed diagnostic case on 59-year-old. Patient has a juvenile onset diabetes, 3-month history of severe exercise angina, anomalous right coronary cannulation was extremely difficult, required multiple catheters, test injection to locate, but the RCA was free of significant disease. Multiple catheters and test injections were also required to image the left coronary artery, which had a minimally diseased circumflex but a severe stenosis at a calcified LED diagonal bifurcation. So this case, complex LED diagonal now. Both the LED and diagonal large territory, LV angiogram shows normal EF, plan for this patient would include. So these are many of the questions that I made those questions, which actually, they ask you to make the questions before the examiner, so they like the questions at all. Many of them I have made it. So question is, this is some of the expected, may come, whether I become the part or not. So question comes is, what would you do in this case, in real life? Very complex, you have done a lot of diet. That is absolutely correct. This patient, postpone the intervention. Don't do the intervention now. Now, if this is subtotal, patient start having chest pain, then you do now. Otherwise, delay the intervention. Very, very important. Most of the, when there is a question comes, which you don't making sense, you just think about that, what we'll be doing in the cath lab. And that's what the answer is. Nothing rocket science. Just what you will do in the cath lab, in real life. Okay. The 75-year-old patient, stable angina, has a history of DES placement in the LED approximately 5 years ago. Angiography reveals 50% narrowing. OCT performed and shows a lesion shown here. Which of the following is true about the lesion? First thing is, what is the lesion? Patient had a stent before. Is it? Calcium. So it's a neoatherosclerosis. That's why they want you to know. It's a neoatherosclerosis. It's not the ISR. We showed you the ISR picture. Okay, so this basically is the extension of the underlying process, virtue stent thrombosis. No, so this basically answer is D. That more commonly occurs with the DES compared to BMS. And it occurs not at 1 or 2 years, after 2 years. Neoatherosclerosis, but faster in the DES compared to BMS because of delayed endothelialization. And these are the cases which I have put it here together for your point of view. Stent under expansion, uniform neointimal hyperplasia. This is intimal hyperplasia case 1. See, very good. Then we have this lipid calcification and stent area significantly smaller than that's under expansion. So those are the findings which we have given to you. 43-year-old male referred for coronary angiography. Patient has exercise. He developed some chest pain. 8 minutes, Bruce protocol, ECG, echocardiographic changes, no evidence of ischemia. Had chest pain, but no ischemia. The exercise test is interpreted as equivocal and the undergoes angiography. Demonstrate a 40% calcified left main lesion. Using IVAS, the minimum lumen area determined to be 7.2 millimeters. Select the best management of this case. Equivocal stress test, chest pain, and the Ivers Lumen. What is the significance for left main? No, 5.5 or 6. Remember, for intervention, some data have 6 or some have 5.5. Less than 5.5 or 6 means significant, more than that is not significant. So this patient should get what now? Cabbage, balloon angioplasty, DES, reassurance and no revascularization, rotational atherectomy with DES because of calcium. Right? This patient, the reassurance and no revascularization, does not have a significant disease. Now, real question, what do you think this patient has? Microvasculature angina, microvascular disease, absolutely. If there is a choice there, this patient likely has, let's say, revascularization is not there, so likely has microvascular angina, the answer is microvascular angina. Okay, so this is intravascular imaging as you need. Left main less than 5.5 and they basically still remain 2A and indications not a class 1 yet, but they will be made class 1 soon. Okay, stent thrombosis. They'll ask you this question in one way or other. The timing 36 to 48 hours after procedure defined as hyperacute, acute, late, subacute, very late. Yeah, so remember acute is 24 hours. Subacute 24 hours to 30 days. Then become late and very late after 1 year. Acute definition, and then we call a definite versus a probable. Definite is that you know there's a thrombus. Probable means patient has a 30-day unexplained death. Anytime they say unexplained death, you have to call it probable. Or MI following target vessel if you have a MI, but you didn't do angiogram. So that's probable. Possible is any explained death beyond 30 days is called possible. And then 30 days, acute within 24, subacute 24 to 30, 30 days to 1 year and more than 1 year. Remember this, they'll give you scenario of one case at least to fit into which category? Definite, probable and timing. Okay, this patient has a small troponin release found to a multivessel CAD with a distal left main which is 60%. One view, 30% in other. Patient has distal LAD 60%, RCA 60, but no evident disease and the circumflex. What should be done? Cabbage for left main stenosis, FFR measurement of the left main into LAD, FFR measurement of the left main into circumflex, medical therapy, or stenting of the LAD stenosis, measurement of the left main stenosis with FFR. What would you do here? First thing is, they want you to establish, is there a left main disease? Remember when they're giving you this, one view is 60, other one is 30, so they're telling you in your mind, you're not clear. So you need to establish. And then if you establish, patient who has already LAD disease angiographically, where would you put the wire? In the left main, into the circumflex. The answer there is the circumflex, that you do FFR measurement into the circumflex. If it is decreased less than 0.8, then this patient, by exam point of view, should go for cabbage. Okay. All right, Medina classification. Which A, B, C, D, E. Which one is this? B. Very good. That's very nice. Okay. Which of the following mechanisms may lead to image shown in figure? Arterial remodeling, decrease in the plaque, dissolution of gel material, stent under expansion, ABC. So this is basically poorly, the under expansion or the maldevelopment stent, and this is late about malopposition, incomplete malopposition, which is at the baseline, follow-up, thrombus dissolution, positive remodeling, stent under expansion are the causes of this, and it's malopposition. Late malopposition is not associated with stent thrombosis. Remember that. The few data have shown late malopposition not associated with stent thrombosis. Okay, this is a good one and simple one. That which one is what? What is one of these? The catheter kinking, damping, normal aortic waveform, normal ventricular waveform, ventricularization. What is number 1? Ventricularization. Very good. Number 2, damping. Number 3, kinking. 4, normal aorta, and lastly normal ventricular function. Ventricular tracing. Beautiful. Okay, 64-year-old woman admitted with progressive angina, coronary angiography, Medina 111 of the LAD and first diagonal vessel. Diagonal is a 2.7 millimeter vessel. Its takeoff from the LAD is almost 90 degrees. The operators are considering two-stent approach and wish to perform lesion preparation with guide wire in both vessels. Which of the following would not allow the operator to maintain two guide wire during lesion preparation? Rotablation, laser, A and B, cutting balloon, and IBL. Only one. lower ventricle. You can leave in the laser. That's where confusing you. Laser, you can leave the wire, but not in the rotational atherectomy. Okay. The trial, this is probably will be the only question which you'll have. BVS trial, they'll still ask you the question because the technique was there, may come back again. That what was the truth for the BVS versus DS trial at 3 years? BVS has lower MI, BVS has higher late thrombosis, BVS has higher acute, subacute thrombosis, BVS has higher mortality, BVS has higher TLR, TVR versus DES. Late. Remember, it was a late thrombosis, which really after 3 years when BVS was being absorbed, the strands, and many of them were not on antiplatelet therapy and developing thrombosis. So that was the question there. And these were the trial, absorb versus giant. Definite and late thrombosis was the issue, higher in the absorb versus the giants. Okay, should be simple, which is not the JCTO score. As you can see here, or favorable. That, or which is the, you can say it this way, that which one is the successful quick CTO, means favorable, your JCTO score. Tapered, stump type. Yeah, right? Otherwise, ambiguous cap is not good. Everything else, and this is the JCTO score, all the points I have made it, and what we say, easy, intermediate, difficult, and very difficult with more than 3. Okay. Following the statement of the result Excel study, that makes at 3 years similar, CV was significantly higher in the cabbage, higher mortality trend from 30 days to 3 years in PCI versus cabbage, but TLR was higher in PCI versus cabbage, stent thrombosis was lower with the graft closure at 3 years. So basically, accept means what is wrong. And the wrong is CVA was significantly higher in the cabbage. No, it went through. No difference. You can see there, mortality started getting little positive at 5 years in favor of cabbage versus PCI. Noble study we already talked about, that higher stroke rate. Okay. Comparing IFR, FFR, stable CAD shows the following. FFR had higher mortality, IFR had higher urgent revascularization, FFR group had lower overall revascularization, similar outcome between two strategy, IFR group had higher procedural side effects. Right? So, yeah, basically the D, similar outcome between the two strategy. This is at 1 year, and the defined flare, individual outcomes, IFR, sweetheart, similar outcomes as shown here. Clearly, the lower side effects in the IFR group were compared to FFR. Okay. PCI is acceptable alternative to cabbage and treatment of left main in following scenario except syntax score 25, additional proximal LAD disease, trifurcation, additional LAD and RCA with syntax score 29, left main lesion with long-term survival less than 1 year due to cancer. So key is what they're saying is PCI is an acceptable alternative to cabbage in the treatment of left main following scenario except. So means which one should go for cabbage? Except means which is wrong. Not the PCI. Remember, except word which is wrong. Then the trifurcation, everything else you can do. They should go for cabbage. So C should go for cabbage. Then the patient guide wire has been advanced across the severe stenosis. Very important. However, several attempts to advance 1.5 millimeter balloon across the stenosis have been unsuccessful, or they may say 1 balloon. Which of the following next step is least helpful? Attempt to advance another wire, use a guide liner, use a laser, use a microcatheter to exchange for extra support wire. What is the least helpful? You cannot put a second wire, so tough. So second wire, don't even try. Best is the laser, but you can do other technique, but definitely don't waste time with a second wire. Your balloon didn't go, your second wire will not go. Okay, so these are our criteria of the OC. Patient with a class 3 chronic angina, has FFR measured in isolated 50% LAD disease, found to be 0.65. No non-video test is available. This operator PCI, elect to PCI lesion rather than institute medical therapy. What will be the OC rating for this case? So patient has a proximal LAD lesion and FFR is positive. So is it rarely appropriate, maybe appropriate, or the insufficient information to decide? FFR makes you appropriate. Okay, so basically C, and these are the criteria. As you can see, proximal LAD, they give extra, right, the extra benefit for it. But anytime you do FFR, become class 1 indication, and so. Okay, following the ideal scenario for IV cangrelor use, except MIACS patient hemodynamic instability, cardiogenic shock, patient with a DS 1 month ago needs urgent surgery, patient with high risk angio feature, stable CAD with 90% proximal LAD, ACC type B2 lesion. E, right? It is a simple case. You don't need IV cangrelor in this particular case. And they clearly say that to be patient undergoing PCI who are P2Y inhibitor naive, intravenous cangrelor may be reasonable to reduce periprocessal ischemic event. And they go on further to show that what are the groups where you have, particularly those who are acute coronary syndrome, and those are the high risk PCI group where you use IV cangrelor. Okay. Patient develops sudden slow flow after PCI, LAD without dissection. Next step. Stent the lesion quickly, nitroglycerin 200 microgram, nitrite 50 microgram, verapamil 50 microgram, IV TPA. Nitrite. Okay. What is the, because what about verapamil? Verapamil dose 50 microgram is wrong. It should be 250, right? Nitroglycerin does not does not help in the slow flow. So basically, if the nitrite 50 microgram, adenosine should be 80 to 120 microgram, verapamil 250 to 500, cardiogram 250 to 500 in case they give you any other answer. Okay. Then this is actually from the trial. I don't know whether they will ask you that patient with a low ACT, you're using 2B3A, they usually want to give you 25 unit per kilogram if your ACT is less than 200. And which is what? This you need to remember. The F6imab, although the molecule has been discontinued, no longer available, but what is the half-life and platelet bound half-life? What is the receptor ratio? Just remember this slide. Very, very important. And that is why if any time patient has our right now available is integral or tirofiban. So of these patients, if they require to be taken out, platelet transfusion is not going to work. Why there is so much high concentration of the drug in the circulation? They'll bind into the platelets. So then it has to be that patient has to plasmapheresis. Platelet transfusion is not going to work. So you need to remove the 2B3A from the blood. F6imab, you need to reverse, then you can give platelet transfusion. Okay. This is another simple question used to be, I don't know whether it will come now. Patient, when we used to use a lot of enoxaparin, ACS with aspirin clopidogrel, last dose of enoxaparin was 7 hours prior. Now best option is do PCI without extra anticoagulation, add 2B3A and heparin, additional, add enoxaparin 30 milligram IV and proceed to IV. It's 7 hours. So 8 hours was the cutoff. 8 hours, you do, after between 8 to 12, you give 1/3 dose. Less than 8 hours, on enoxaparin, you do PCI. After 12 hours, you do a regular dose. Okay. Following, yeah, this is important. Will be one way or other will come this question. One of the following statement regarding arterial remodeling after PCI, all are true, except, again, which is wrong. Restenosis after PTCA is a balance between intimal hyperplasia and new formation and arterial remodeling. Arterial remodeling is described as de novo atherosclerosis as well as post-angioplasty. The arterial remodeling is defined as constriction or shrinkage of the vessel with loss in coronary diameter after PCI. And coated stents basically eliminate arterial remodeling. So question is, which is wrong or true? What is basically wrong in this particular case? Remember what happened in the cases, what we do when we put a balloon atherectomy, the whole vessel shrinks. The major mechanism of restenosis after balloon or atherectomy is negative arterial remodeling, not an instant restenosis. Intimal hyperplasia occurs in the drug-eluting or other stents. So very important answer there is that basically the restenosis after PTC is the balance between intimal new information and arterial remodeling. No, it is majority of the arterial remodeling. And so, okay. Patient has underwent PTCA, stent of the 95% proximal RCA 9 months ago. He called to arrange the diagnostic cath. Very adamant that he wants to have an angiogram because one of his friend just got a trouble because had also PCI a few months ago. Which of the following statement is true? You're basically saying that patient has no symptoms but wants an angiogram. Okay, 75% patient with angiographic restenosis develop symptoms. The stent restenosis is reduced by 60% compared to PTCA. The progress of asymptomatic stent restenosis is excellent. The repeat PCI or asymptomatic restenosis lesion is indicated to decrease likely future risk of anginal symptoms. So answer. So basically, the trial showed what? Our 75% patients with angiographic restenosis develop symptoms? No, it's a 50%. Then restenosis rate reduced by the DES versus PTCA was only 30%, not 60%. Prognosis of asymptomatic stenosis is excellent. So answer there will be C. As you can see, only 50%, 30%, and no, if more than 9 months, that patient is not going to come back. Okay. Again, same. 82-year-old female died in sleep, nursing home 18 months after implantation of DES. Which category? Possible, probable, definite, late, very late? I just went through it, right? So it's the possible, primary, very late stent thrombosis because died. We don't know anything. If you have some MI, then yes. But unexplained death is the okay. Then let's go to the 67-year-old man undergo bypass surgery for severe 3 vessel. 12 hours after the surgery, patient becomes short of breath, 3 mm ST elevation. Management basically what they want to do is patient post cabbage got trouble, graft occluded, thrombosis. Those patients not managed medically, they come to the cath lab. So answer there is you bring the patient to the cath lab and intervene. Okay, the bifurcation lesion measurement fraction FFR on side branch is more than 50% angiographic residual narrowing after stent placement. Following are the two findings. Most lesions, we know that lesions have FFR of more than 0.8, even if angiographically it looks like 50, 60, 70% blockage and so. Okay, then all these trials of the champion IV cannulor, what basically showed that it decreased the, no difference in MACE and decreased the minor or moderate bleeding, but not the severe bleeding by using the cannulor. These are all the data on the cannulor versus clopidogrel, which I have put it together in safety endpoint. Then Pioneer AFib PCI trial, which is a compare rivaroxaban versus warfarin, both group. And the question is 1 year follow-up, what were the main findings of the trial? That irrespective of the DAP or rivaroxaban dose, warfarin was associated with higher rates of clinically significant bleeding. Okay, good question. 58-year-old male, person had hypertension, acute onset of severe tearing chest pain that radiates to back, ECG, sinus tachycardia, LVH, no evidence of MI, creatinine is 3.9. Which test would you order next to establish a diagnosis? Right? You do a CT angio, but in this particular case, what you do, not a proceed with CT surgery yet, but you need to make a diagnosis by the TEE. Okay. This is also the degree, how the subsequent restenosis develop in patient with a new atherosclerosis is a, I have the question there. Okay, this is fine. So this is about the question which we have spoken about. Patient has the Canadian class 3 symptoms at a cabbage, and that time patient has a SVG2 RCA, which is chronically occluded, SVG2 first marginal, SVG2 LAD, in the presence of calcific subtotal left main. This patient, prior to current presentation, intermediate lesion in the SVG2 LAD and SVG2 RCA were seen on the coronary angiogram, but treated conservatively via PCI with a drug-eluting stent was placed in the SVG2 marginal branch to treat critical lesion. Current angiogram shows that SVG2 first marginal is patent, SVG2 RCA is occluded, and SVG2 LAD has an extensive disease. Which of the following statement is most appropriate? So that's the question. Remember, this we talked about it in this particular case. The answer is all of them. Most important is they want to say the IMA graph is available. A choice of redo cabbage is also good in this particular case. Then intermediate stenosis LAD FFR 0.7 perform. So key is what do you do when FFR is less than 0.7? That once you do the PCI, their outcome becomes just like your outcome of the FFR of more than 0.8. So this is another the question in patient that the patient who has hypotension, you put a hemodynamic support device. Okay, patient with heparin-induced thrombocytopenia. The following agent could be used. Bivalodin, enoxaparin, fondaparinux, ergoparin, both bivalodin plus ergoparin. E is the answer. Then following predictors of calcified lesion except kidney disease, old age, diabetes, left main, and Hispanic race. Multiple trials have shown Hispanic race, they don't develop calcific lesion compared to others. Long-term DAP in the DAP trial is associated with the following except lower mortality, higher bleeding, lower stent thrombosis, significant lower MI, and lower MACE. Answer is not mortality. Everything else was better in the extended DAP trial. We have talked about XL and Noble trial. Basically, is that consistently higher CVA in the cabbage group in both the trials because that's wrong. Because only Noble trial was higher CVA rate. Syntax 2 study, which we have spoken about the C. Let's go to aspirin rivaroxaban, COMPASS trial, that higher decay crush. Left main bifurcation revealed the following except lower revascularization was conventional, lower MI, lower stent thrombosis. 2 stents were compared with 1 stent strategy in all cases, similar mortality versus conventional strategy. What is the, except what is wrong? It was not the two stents were compared against the, in all cases. Word is all cases. It was provisional, right? And basically, the two stents were compared with the one stent strategy in all cases. And basically, the question was that how many patients require the second stent? About 45% require second stent on the side branch. This is with the switch. You'll see FAME3 trial. We have already spoken about the outcomes of the FAME3 trial. Okay. This is also randomized trial of the CTO comparing PCI versus medical therapy of following results. Improve MACE, lower MI rate, improve LVEF, lower end diastolic volume after PCI, and none of the above. Answer is none of the above. All trials have been negative. There was a trial done even for the end diastolic measurement was negative. Okay. Patient coronary angiography have a single RC stenosis of 60%. FFR is measured to be 0.8. This could be best said about the revascularization in this patient. What will do? Revascularization going to decrease the urgent revascularization based on the FAME2 trial. Okay, so this is about the calcium modification, which we say that calcified lesion have similar stent expansion or less calcified lesion. Answer is this was wrong because calcific lesion will have a lower stent expansion. Okay, so this is following statement is truly reflect the current data on use of potent P2Y12 inhibitor after ACS PCI. That is perceived in higher stent thrombosis with clopidogrel use, higher MACE rate with clopidogrel use. There is a higher stent thrombosis with a potent P2Y12. There is higher bleeding, use of potent P2Y12, and frequently used in post-ACS PCI currently. So question comes in real practice, what is the current is the D, higher bleeding with the use of potent P2Y12. Current multiple data has shown compared to initial Triton and Plato that no difference in compared to clopidogrel in those trials. Okay, then same. ACCHA and protected left main, stenting in a patient with ostial left main disease. A syntax score is 15. Operative mortality is 5%. You know what is counted as a high STS mortality? More than 3%. So this patient has high STS mortality. The question is which category this patient will fit in, 2A or 2B? Clearly because of the high, this is not a surgical case, it's a 2A. Surgical case could have been 2B because low syntax score. Shock trial, you know, basically, said a little bit earlier, the revascularization, two-stent technique. We had spoken about that if the side branch, you cannot get it, you go with a two-stent approach. Okay, yeah, good. Which pairing does not reflect an important use of the associated imaging technology prior to planned PCI? OCT and ostial left main, IVUS and stent diameter selection, NIRS, IVUS and prediction of emboli, IVUS and stent expansion optimization. Exactly. A, very good. Okay, which of the outcomes, the following left main disease trial comparing PCI with CABG? Higher 5-year mortality, similar 10-year mortality, similar 5-year mortality, higher CV rate. So Excel trial was higher 5-year mortality. Similar 10-year mortality basically was our pre-combat trial. Similar 5-year mortality in syntax, higher CV rate in the Nobel. Okay, now which is the inner lumen diameter of the commonly used 6 French guiding catheter? Yep. So 0.72, very good. Then what is the most appropriate strategy in a freshly deployed underexpanded DES? Underexpanded, freshly deployed. Rotablation, orbital, laser, or shock wave? The answer there is shock wave, although people may use laser, but the answer for it is shock wave now. And then the OCT is better than IVUS to delineate which intracoronary imaging parameter. We already talked about it. Calcium. Stent has the thinnest struts with the width. We talked about Orsiro. Okay, which stent has the biodegradable polymer? Synergy. Okay. Which bifurcation lesion most likely to need bailout stenting of side branch in the single stent approach? Clearly, the lesion length more than 10 millimeter. You need to remember all the time. Then left main bifurcation lesion, which is the site of most frequent ISR. It is the ostial circumflex. Okay, so ostial circumflex is the most common. Then, you know, remember the old data of the Freedom trial, higher mortality with the DES. In the second generation DES, a lot of papers have shown no increase in higher mortality in diabetic patients with the second generation stents. Okay, this one is good. Recent guideline about the PCI of the non-culprit vessel in ACS is true, except, means which one is wrong? FFR may be recommended for intermediate lesion before proceeding for the PCI, and interval stress test is essentially needed before deciding. Stage PCI in the same hospital admission is preferred. Non-culprit vessel PCI can be done at the time of culprit vessel PCI. Non-culprit lesion PCI can be done in severe stenosis without any further testing. What except means which is wrong? You don't do interval stress testing, so that's wrong. So B is wrong. Okay, all that could be done same time during hospital admission. Angiographic guided is completely fine. CTO, I mean, once you develop tamponade, you just all need to know, always have a trouble, short term or long term in those cases. Okay, so this is a case. Patient has a hypertension, nephropathy, baseline creatinine 3.5. You found to have 70% osteal RCA disease on diagnostic angiogram. Now, which of the statement is false with regard to his planned PCI and CIN? Staging the intervention for at least 72 hours, and then use of a JR4 guiding catheter with side holes, then CIN defined as absolute increase of more than 0.5. Calculation of the EGFR will help, and rapid fluid administration for 2 hours will not reduce CIN. Basically, we don't check GFR. It is an absolute increase in the creatinine, which is materialistic in these cases. Okay, the patient stent of calcified mid-right coronary stenosis, we're advancing the stent. Unfortunately, your guide catheter and wire balloon abruptly fall out of the vessel. You note that the stent seems to be left behind, halfway pushed into the lesion, and patient becomes ischemic. Your best treatment option is send the patient for emergency surgery, attempt to place a wire through the stent, followed by a low-profile balloon, and retrieve the stent, attempt to snare the stent, and pass a wire adjacent to the stent and compress the stent against the wall. What do you do in real life? Put a wire side by side and compress the stent. You're going through the hole, unexpanded stent will be very tough. So this is what we do. Basically, compress the stent. Rotational atherectomy, I think you'll see this very simple. Trouble has been that reduced restenosis is the big issue. Okay, that's a good one. They will ask this question. Which of the following factor associated with coagulation is not released from the activated platelets? Little science question. Fibrinogen, ADP, tissue plasminogen activator, pi, or platelet factor 4, which is the TPA, is not released by the platelet, everything else. Okay, so this is as usual when we discontinue those agents. Following statements are true, predominantly platelet rich. Yes, this is a good one. All the type, parts have been shown by Moreno. Pulmonary embolism is predominantly fibrin rich. Coronary thrombosis in ST elevation is platelet rich and fibrin rich. Natural anticoagulants include protein C, protein S, and tissue factor. And plasminogen activator inhibitor is decreased in patients with diabetes. No, it's increased. So therefore, answer is natural anticoagulation are not protein C, they are anticoagulant. This is the patient, simple, the patient has a spasm, so you give a nitroglycerin for the right coronary artery. Okay, so this is the good case. Let's go through this one. We have 10 more questions and then we'll finish it. The patient undergoes treadmill nuclear perfusion imaging, annual examination, recently began exercising, maintaining his health, and has no cardiovascular symptoms. Exercises for 4 minutes and developed 1.5 millimeter horizontal ST segment depression and returns to normal after 5 minutes. He has no chest pain during the study. His nuclear imaging demonstrates impaired coronary flow reserve in the anterior and anterolateral effect. Vessels with mild dilatation. Select the best management. Because he is asymptomatic, you recommend continued medical therapy, or you order a cardiac MR perfusion study to confirm the myocardial ischemia. You schedule a coronary angiogram, and none of the above. What do you do for this case? Schedule angiogram. No question there. This patient could have even left main disease. Good. Then the patient with prior MI 8 years ago, coronary angiogram, and moderate exertion, climbing stairs, has no unstable feature of the chest pain. Coronary angiography demonstrates a 20 millimeter long calcific total occlusion of the mid-right coronary with a brisk collateral and vessel distal from the LED. Select the best management. Rotational therapy followed by DES, pre-dilatation of the DES, local infusion of fibrillating and none of the above. Basically, medical management. So this is actually a little question, may not come now, that what were the basic difference of the cabbage versus medical therapy trial of multivessel disease in the past, and basically was that the patient relief of angina with a cabbage, except in some subgroup there was decrease in mortality like left main, three vessel disease with low ejection fraction. So then the patient cabbage versus PCI, I have put a question answers there. Total occlusion is most common in RCA, least in circumflex. And then, okay, ACCHA classification. Which of the following true regarding the influence of lesion length on the AHA-ACC classification lesion type? Lesion 2, type B1, 2 centimeter length presents at B2. Lesion 10 to 20 millimeter represent type C lesion. Yeah. So basically, in this particular A, okay, these are the ACCHA classification. Make sure you remember the type C, diffuse, excessive tortuosity, extreme angulation, inability to protect side branch, and degenerative vein graft. They'll ask you one of those questions. Still very old, but they all want you to know because they still count as a B2 and C lesions when we grade them. Which is the most specific platelet inhibition test? So there are question P2Y12 receptors. They say either flow cytometry or light transmission aggregometry. One of them. Both are A and C are correct. So those are the more specific tests for your platelet inhibition. Pressagul, when compared to, basically Pressagul is the better effectiveness. The trial, you remember Triton trial, and then Triton with the DS for BMS, stent thrombosis lower, and patient with acute coronary syndrome. Pressagul is not needed. Patient with ACS, when you're not planning PCI, the Pressagul is not needed. You can give ticagrelor, not the Pressagul because of the trilogy, because Plato still have the medical therapy arm where ticagrelor did better. Then, following is true about ticagrelor, except is a non-theoropyridine. Clopidogrel inhibits platelet aggregation to a greater degree compared to ticagrelor. In the Plato trial, ticagrelor use resulted in decreased incidence of composite endpoint of cardiovascular death, MI, and stroke. And then the rates of non-cabbage TIMI major bleeding were greater in the ticagrelor group compared to clopidogrel treated patient. Yeah, so basically B, okay, inhibits platelet aggregation is wrong. Plato trial, all the individual data. Case number 110, Triton TIMI 38 is the same, will be that patient who had the stent thrombosis was similar in Pressagul versus clopidogrel. No, basically there was a lower stent thrombosis in the Pressagul group. Okay, duration of dual antiplatelet therapy in ACS after undergoing stenting should be that what you need to remember two things now. They want you to do 6 months DAP in stable CAD, acute coronary syndrome 12 months DAP. If patient is high risk bleeding, 3 months DAP. Okay, and then anytime after 1 month you can take away the aspirin. Once you have this four in the mind, you'll have 1 or 2 questions pertaining to that. Okay, so this case is should be given for 12 months. Pressagul can be given for 6 months after PCI. Ticagrelor can be given for 3 to 6 months after PCI. Option include clopidogrel 75 milligram daily, Pressagul 10 milligram daily, ticagrelor 90 milligram daily. So clearly the A and D will be the better answer. This is the guidelines of our ACCHA, which looks into that, and also the decreasing to 3 months patients who are bleeding risk. See that? In the 3 months for the patient with a bleeding risk. Okay. Then the question comes is that when we talk about the intention to treat analysis, so which is better? Compare always is superior to a per protocol analysis for maintaining the benefit of the randomization process. Remember, intention to treat. What is that advantage against the per protocol? Cardiogenic shock, which we all know that is a frequency still has not changed. Mortality is still around 40 to 50% at 30 days. Yeah, we have spoken a little different type, but it's the same way that high volume center CTO PCI success rate should be more than 90%. Then, okay, patient multivessel CAD, diameter stenosis of the LAD 50-50, all 50, the least likely to have a positive FFR. Is it equal in all vessels, or which vessel has likely to have a least positive FFR? Because the area which supplies the least muscle, which will be circumflex. Similar stenosis, area with a similar length, degree, the circumflex will be more negative. Okay, most predictive of the subsequent clinical event, basically is your minimum lumen area less than 4, plaque burden more than 70, presence of thin cap atheroma is the most predictive of subsequent event. Okay, this patient has a two-pack history, underwent DSPCI of the mid-LAD. Final angiogram showed a well-expanded stent with a TIMI-3 flow. Following morning, a routine troponin 1.5 milligram was measured. Patient remained asymptomatic, and his cardiac examination was normal. And his electrocardiogram showed non-specific ST wave changes, which were unchanged from the admitting EKG. The best course of action for this patient now is discharge the patient, bring the patient back to the cath lab, transfer the patient to coronary care unit, continue to monitor patient telemetry for 24 hours, check another set of troponin, and if it goes down, discharge. So key basically what I'm trying to say is asymptomatic enzyme elevation is usually benign. What you do is you may just repeat it, and once it starts going down, you discharge the patient. One, don't measure. If you need to measure, then you have to repeat it and then discharge the patient. So bring the patient back to the cath lab, which is wrong. Everything else is correct. Okay, I think this is the last one. Patient, no, this we already have questions, and I think this is the last. With that note, we'll stop here.